All right, let's dive straight into this explainer for your Step 2 CK prep. We're zeroing in on the high-yield obstetrics content, focusing purely on exam-facing facts. We're going to map out the exact chronology, mechanisms, presentations, and first-line treatments you need to know for test day.
We are rapidly moving through 6 main areas today: liver disorders, biliary disease, pseudocyosis, medication safety, uterotonics, and finally, illicit drug complications. Let's get to it.
Section 1. Liver disorders of pregnancy. So, picture this. You've got a third trimester patient complaining of intense generalized itching. Your immediate reflex? Check the skin. If there's a rash, you're likely going down an autoimmune or derm pathway. But what if the skin is completely clear? If there's absolutely no rash, your differential instantly narrows, and you need to figure out if this is just benign pregnancy itching or a serious pathology with massive fetal risk.
If that itching is worse on the palms of her hands and the soles of her feet, you need to check her total bile acids to confirm intrahepatic cholestasis of pregnancy, or ICP. You see, normal, benign pregnancy itching usually just causes focal pruritus, and those bile acids, totally normal. But with ICP, total bile acids shoot up to 10 micromoles per liter or higher, and you'll usually see a mild transaminitis right alongside it.
Now, what's actually happening here is impaired bile flow, which causes those acids to back up and accumulate. And this directly dictates our management. We treat the symptoms with ursodeoxycholic acid and histamines. But the really critical part is planning the delivery. Why? Because there's a huge risk of intrauterine fetal demise, especially when those bile acids cross the 100 mark. We're also talking severe risks like preterm delivery, meconium-stained amniotic fluid, and neonatal respiratory distress. Because of all this, you're typically planning delivery right at 37 weeks, or even earlier if those levels are dangerously high.
All right, let's look at this breakdown comparing HELLP syndrome and acute fatty liver of pregnancy. You absolutely have to keep these two separate for the boards. HELLP is inextricably linked to preeclampsia. You're going to see hemolysis, elevated liver enzymes, low platelets, right upper quadrant pain, and usually hypertension and proteinuria. Now, acute fatty liver of pregnancy, or AFLP, is a totally different beast. It's a microvesicular fatty infiltration driven by abnormal maternal fetal fatty acid metabolism. Your big glowing exam clues for AFLP: profound hypoglycemia, elevated bilirubin, DIC, and fulminant liver failure.
The scary thing is, both of these conditions rapidly spiral into multi-organ failure. And that means immediate delivery is your definitive management step, regardless of the gestational age. With HELLP, you're delivering to stop the microangiopathic hemolytic anemia and low platelets. With AFLP, you have to deliver to halt the disseminated intravascular coagulopathy and liver failure. It's that serious. Moving on to Section 2, biliary disease in pregnancy. Pregnancy actually creates the perfect storm for gallbladder issues. Estrogen increases biliary cholesterol excretion, while progesterone basically puts the brakes on gallbladder motility. This leads directly to gallstones, which you'll easily spot as echogenic foci or sludge on a right upper quadrant ultrasound. The classic presentation? Recurrent, postprandial epigastric or right upper quadrant pain that resolves in a few hours. Notice there's no fever or leukocytosis. That's what separates it from acute cholecystitis.
So how do we manage it? First, you attempt conservative management. Think IV fluids and pain control. But if you have a complicated or reoccurring case and surgery simply cannot wait, you want to target the second trimester for a cholecystectomy. Delaying until postpartum is always preferred, but if you have to operate, the second trimester is definitely the safest window.
Section 3. Pseudocyosis and somatization.
The classic vignette here is fascinating. You have a patient presenting with extreme physical signs of pregnancy: amenorrhea, abdominal distension, maybe even morning sickness. But your diagnostics, like the pregnancy test and ultrasound, definitively rule out an actual gestation. This is pseudocyosis. The patient's belief is so deeply held that they might even misread a negative home test as positive. It's often triggered by severe psychological stressors, like difficulty conceiving, which can literally alter the hypothalamic pituitary ovarian axis. Because this is a severe manifestation of somatization, you have to tread carefully. You must handle the patient with supportive communication while immediately engaging psychiatry. Remember, they aren't malingering or faking it. This is a real psychiatric condition that needs a careful, multidisciplinary approach.
All right, Section 4. Pregnancy medication safety.
For the boards, you need to know exactly what's safe to prescribe. When you get a vignette about asthma during pregnancy, lock this in. Both inhaled beta agonists and inhaled corticosteroids are completely safe. You never step down asthma control just because a patient is pregnant. Keeping maternal oxygen levels up is absolutely paramount for the baby's health.
Section 5. Uterotonics and drug toxicities.
Okay, let's talk about magnesium. It is solely renally excreted. That means if a patient has renal insufficiency, it accelerates this terrifying drop down the toxicity ladder. You go from mild nausea, flushing, and hyperreflexia straight into areflexia, somnolence, and ultimately respiratory paralysis and cardiac arrest. You'll also spot hypocalcemia because of a temporary suppression of parathyroid hormone. Oh, and here's a massive must-know exception. If the patient has myasthenia gravis, magnesium sulfate is totally contraindicated because it triggers a myasthenic crisis. For those patients, you use valproic acid for seizure prophylaxis instead.
And for your definitive rescue step, the literal second you notice hyperreflexia or dropping respiratory rates, you shut off that magnesium infusion and push IV calcium gluconate. No hesitation.
Now you have to memorize this strict uterotonic matrix for the exam. Methylergonamine is an ergot alkaloid, absolutely avoided in hypertensive patients. Carboprost is a PGF2 analog, absolutely avoided in asthmatic patients. Then there's misoprostol. It's a highly versatile prostaglandin used for cervical ripening, labor induction, abortion care, and hemorrhage management. But you have to be super careful using it in patients with prior uterine surgeries.
Let's look at oxytocin. Because its structure is so similar to antidiuretic hormone, it sets off a very predictable cascade. It causes water retention, which leads to severe hyponatremia, and that can cause central nervous system impacts like seizures. If that happens, your rescue is hypertonic saline. Remember, oxytocin is released from the posterior pituitary right alongside ADH, so at high continuous doses for induction or hemorrhaging, that structural cross-reactivity is a huge deal. You also need to watch for its other major adverse effects: rapid, severe hypotension, and uterine tachysystole. That's defined as more than 5 contractions in a 10-minute window, by the way. Also, keep in mind that oxytocin is basically useless in the first or second trimesters for expelling retained products, simply because the uterus hasn't developed enough oxytocin receptors yet.
Finally, Section 6. Illicit drug complications.
The big clinical flags here include adolescent pregnancy, late or inconsistent prenatal care, and notably, inadequate weight gain throughout the trimesters. If a vignette gives you a patient who's dodging appointments and failing to gain appropriate weight, your index of suspicion for substance abuse needs to shoot way up.
It's absolutely crucial to recognize how these maternal risk factors map directly to devastating outcomes. We're talking spontaneous abortion early on, progressing to preeclampsia, abruptio placenta, severe fetal growth restriction, preterm birth, and intrauterine fetal demise. These aren't random. They are the direct vascular and placental consequences of illicit substances. So, the next time you see unexplained fetal growth restriction or sudden placental abruption in a question, you really need to consider the quiet, underlying mechanism of illicit drug abuse driving that pathology.